Hi, my name is Grant McKinnon, and I am a transitional year resident in the class of 2022. It's my absolute pleasure to introduce you to the ICU and a lot of the intricacies that make it such a special learning and working environment. I want to first start with saying that the ICU, given its high acuity and complexity of patients, I want to talk about topics that you might not have to think about very often on the wards. And one of my disclosures is that the topics hope to provide a framework for common clinical scenarios, but will not apply to the care of all patients and the care of all attendings. So I think a good place to start would be talking about oxygen support and when someone might need to be transferred to the ICU for a higher level of care. So at the bare minimum, we can place someone on nasal cannula. And nasal cannula is our least invasive form of an open system. An open system meaning that it is not closed off to the external environment. Someone is still breathing natural airborne oxygen. And nasal cannula can give 1 to 6 liters per minute of oxygen. And with the patient breathing the oxygen from the nasal cannula and breathing atmospheric oxygen, their inhaled oxygen ranges from about 25 to 45%. Now, higher up on the spectrum is a non-rebreather, and that can go from about 6 to 15 liters per minute. Now, the non-rebreather has a more closed system, but it's still considered an open system, and patients can achieve an FiO2 of around 60 to 90% oxygen. Now, heated high flow can go anywhere from about 6 liters up to about 60 liters. Now, heated high flow has an additional component where the percent oxygen can be manipulated. Now, the percent oxygen can go anywhere from 21%, which is atmospheric oxygen, all the way up to close to 100%. Now, the FiO2 will range between 30 to 100%. It won't get quite up to 100% because it's still technically an open system, and some atmospheric oxygen will be inhaled, but it's about as close to 100% FiO2 as you can get. Now, once we start getting to the closed systems, that's when patients either have a mask or we're able to remove the breathing mechanics from the atmosphere, and that would include ventilatory support. Now, CPAP and BiPAP, they both require masks, and they have the additional limitation of not being able to use restraints. And the main reason for that is if someone aspirates or they throw up, the emesis will be contained within the mask and can lead to aspiration, and that's a big risk. So if you want to have someone on CPAP or BiPAP, you have to anticipate whether your patient will be able to tolerate not being on restraint. Now, for CPAP, the two variables we can manipulate are the FiO2 and the CPAP. So the CPAP would be just the continuous airway pressure that allows for better oxygen and for carbon dioxide exchange. So a typical system would be a CPAP with a FiO2 ranging anywhere from 21 to 100%, and then a CPAP with a pressure of anywhere from 5 to 12 centimeters of water. Now, BiPAP has the FiO2 variable, but now that instead of a continuous pressure, it has two different levels of pressure. So it has the inspiratory pressure and the expiratory pressure. So the inspiratory pressure is going to be that higher pressure that pushes that air to the small airway sacs, and the expiratory pressure is thought as the pressure that maintains the patency of those small airways. So a typical setting after putting someone on BiPAP would be 12/6, meaning that inspiratory pressure is the 12 centimeters of water, and the expiratory pressure is the 6 centimeters of water. Now, last but not least is ventilatory support, which is the most invasive but also the most intrusive form of providing oxygen. Now, we'll talk about each of the ventilator variables, and we'll start off with FiO2, which is similar to the other percent oxygens we talked about, and that is the fraction of inspired oxygen. So, like I mentioned earlier, atmospheric oxygen is 21%, and so the ventilator can provide up to 100%. And being a closed system, the oxygen that actually reaches the end alveoli will be 100%. Now, the PEEP is the positive end expiratory pressure. This is a pressure that helps maintain the patency of these small air sacs and have a direct effect on increasing the intrathoracic pressure. Now, the downside of that is with increased intrathoracic pressure, it will decrease preload. This is very similar to how a tension pneumothorax decreases preload. Now, there are different schools of thought on how this decrease in preload affects cardiac output. The traditional school of thought thinks that this will decrease cardiac output, and there's another school of thought that thinks that while it decreases preload, it actually will decrease afterload and possibly increase left ventricular contractility, which may actually not result in a decrease in cardiac output. Now, there's a phenomenon in ventilated patients called autopeep, and this occurs when a patient hasn't fully exhaled before taking the next breath. And this is typically in patients who are tachypnic, and it can be diagnosed or be discovered by looking at the flow loop, which I'll show you later on the ventilator, and it's when the end expiratory flow is greater than 0. So when we think about different variables, some of these are things you won't manipulate yourself, but they're things that you can bring up. So the first would be inspiratory time. So normal patient ventilator settings are 1 to 2, which is 1 second inhaling and 2 seconds exhaling. Now you can manipulate this. So in patients who are intubated for COPD exacerbations and not necessarily for oxygen support, they might need more expirations. So they might be on a 1 to 3 or a 1 to 4 ratio. Another variable you can manipulate is the inspiratory flow rate. So normally when a patient takes a breath, the ventilator will provide air and oxygen at 60 liters a minute. Now you can increase the rate, which will then subsequently decrease the amount of time required in order to achieve a set pressure if on pressure control, or tidal volume on volume control, which will decrease the risk for autopeep. Now, one of the risks for having someone on the ventilator is that being a closed system, any pressure you introduce to the airway can subsequently cause increased pressure to the small air sacs. And we always have to be conscious about high pressures and pneumothorax, pneumomediastinums, and things like that. So there are two main variables that we look at. So the first is the P peak, and the P peak is just the PEEP plus the inspiratory pressure. And we haven't talked about the inspiratory pressure yet, but the inspiratory pressure is the amount of additional pressure beyond the PEEP that the ventilator will be able to give. Now, when you're on pressure control, this is a set variable, and when you're on volume control, it is a dependent variable. So the P peak is measured automatically, and our goal is less than 40. Now, the P plat is the plateau pressure. And so the plateau pressure is a more direct measurement of the pressure exerted on the small air sacs, and so is a more direct correlate to the risk of pneumothorax. Now, the P plat requires an inspiratory breath hold, so it's something that you actually have to do and manipulate on the ventilator in order to measure, and the goal is to be less than 30. Now, if a patient is desatting, you can measure the difference between the P peak and the P plat. If your difference is greater than 10, it's more of a resistance problem, and this could be a bronchospasm, it could be a mucus plug, or it could be due to you having a high tidal volume if you're on pressure control. Now, if the difference is less than 10, you have more of a compliance problem, which you should start thinking about atelectasis, ARDS, pneumothorax, among others. Now, we have two main types of ventilators at Ball Memorial, and I will show you the screens of each of them and show you where you can find a lot of the information that we just talked about. We'll start on the bottom here. So on the bottom are the main variables that you're going to manipulate. So you have the FiO2 and the PEEP, both on the right, and they're very easy to tap and be able to choose the percent oxygen or the pressure that you want. And on the left side of the lower panel, you have the set respiratory rate. So if the patient is not overbreathing, what's the minimum respiratory rate that you'll allow the patient to have? The inspiratory pressure, which is only for pressure control, and this is that pressure that I mentioned, will be the maximum amount of pressure above PEEP you'll allow a patient to inhale. Now, if we look at the two different waveforms above those variables we just talked about, the top is going to be the pressure waveform. So this is where you can see the peak pressure, you can see the bottom, the trough of the waveform is actually going to be your PEEP. So you'll be able to indirectly see your PEEP. Now, the bottom waveform is the flow waveform. So anything in the positive direction is going to be inspiratory, and anything in the negative direction or below the x-axis is going to be expiratory. And so this is a good way of looking at someone who possibly could be auto-peeping. So this would be someone who would be having flow at the end of expiration, still in the negative direction, before it has to make an abrupt shoot up to the positive inspiratory cycle. Otherwise, some of the more direct or actual measurements are going to be on the top. So the peak pressure is measured at 33. The patient theoretically should be getting the 10 plus 20, so the 10 of the peak plus the inspiratory pressure. So this is just, one snapshot. The actual PEEP is measured at 8.6 here. The IE ratio was set. And then the actual respiratory rate being 29. So this is someone who's overbreathing the ventilator. The tidal volume can be measured here, and this is someone on pressure control. So the tidal volume not being set is something you're definitely going to have to look at. And the minute ventilation, which is just your respiratory rate times your tidal volume in liters. Now, the second ventilator here is the Hamilton ventilator, essentially just a different configuration of all the same variables we just talked about. So the variables you're more going to manipulate are going to be on the right side here. So you have your FiO2 on the bottom, you have your PEEP, you have your inspiratory pressure if you're on pressure support, and then you have your set respiratory rate. Now on your left-hand side is when you can see the more actual measurements. So our peak pressure is 27, and it theoretically should be 10 plus 16, so 26, so that makes sense. Our actual respiratory rate is 14, so the patient is not overbreathing the ventilator, and the tidal volume is about 450. The Hamilton ventilator has an additional measurement called the C-stat, and so this is a measurement of compliance. So anything over 50 is going to be adequate or really good compliance. Now, if we look at the diagram of the lungs here, when the lungs are very sharply demarcated and they're very straight lines of the lungs as shown here, this is the ventilator saying the compliance isn't very well. And so this is, also shown by the C-stat being less than 50. Now, if the lungs were more rounded, as shown by the outer blue pattern here, that would show that the lungs have pretty good compliance. An additional thing here is you'll see a picture of a diaphragm muscle under the lungs every time a patient triggers a breath over the set respiratory rate. So when we think of people being on the ventilator, it's usually of a few different indications not talked about here, such as maintaining airway patency. But two of the main indications we think about are CO2 retention or hypoxia. So CO2 retention, one of the most common things is going to be a COPD exacerbation. And the two variables that we most manipulate in these types of CO2 retainers are tidal volume and respiratory rate. So a higher tidal volume and a higher respiratory rate will lead to a greater removal. Now, you can measure the CO2 venous or arterial, but typically if we're thinking about CO2 retainers, a venous blood gas is good enough. Now, if we're thinking about oxygen, our two main variables are the FiO2 and the PEEP, and these would be people such as ARDS, atelectasis, things like that, pneumonias that are having issues with oxygen. Now, if you're really worried about oxygenation, you should draw an arterial blood gas. The reason why we're talking about this is arterial blood gases have to be from an artery, and so these have to be drawn by RTs. We really want to minimize the amount of ABGs we're drawing because there's arterial punctures, there's risk for bleeding, pseudoaneurysms, and being as understaffed as we typically are in the ICU, not having to take away RTs from caring for patients is usually a good idea when patients often have central access and getting a VBG is very easy. Now, we typically want to get a VBG or an ABG at least 1 hour after major change. So this would be after a new intubation, after having someone who's prone's now flipping supine and you want to see if they can continue being on supine. So this is when you're going to draw the ABG or the VBG. I would say when in doubt, still go for an ABG. They're still in favor. They are a better measurement of oxygen and CO2. But it's really good practice to be able to question which of the two different laboratory values you really need. Now, when we have someone on the ventilator, there are two main different settings that we can have them on, and that is pressure control and volume control. So at a 10,000 foot view, pressure control is just a set pressure that you will not allow the ventilator to exceed that set pressure, and the tidal volume will be the amount of volume delivered until you reach that set pressure. So the tidal volume is very dependent on airway resistance and airway compliance. Now, the risks for this is if a patient has high airway resistance, such as someone in an asthmatic flare, there's the risk for very low tidal volume and a very low minute ventilation. Now, in volume control, you will, instead of setting the pressure, you're going to set a tidal volume. So you are going to set that this patient is going to have a tidal volume of 450, and you will allow the ventilator to hit whatever pressure it needs in order to deliver 450 cc's per breath. Now, the downside of this is pressure. So pressure can be really exceeded if there's a high airway resistance. This can lead to barotrauma, volutrauma, lead to pneumothorax. And so at least the practice in our ICU is typically pressure control over volume control. Now, there are some nuances with a lot of the new ventilators. You can set a pressure control. You can say, I want my PEEP to be 10, I want my inspiratory pressure to be 20, but I want the ventilator to still shoot for around 400 milliliters of breath. And then the ventilator, using its all complex mechanics, will still hit 20 inspiratory pressure, but still try to hit that target tidal volume. Now, the ARDS NET protocol was developed and is a really good framework for thinking about how to manipulate the ventilator. So typically, as you know, with ARDS, there's high risk for barotrauma. And so what we want to do is we want to do low tidal volume ventilation. So we typically shoot for 6 milliliters per kilogram of predicted ideal body weight. So this is not the patient's weight upon admission. It's going to be the weight predicted only by height and sex. So you can go on MD-Calc, you can go on many different websites on the internet to find out what a patient's predicted ideal body weight. So we typically shoot for around 6 milliliters per kilogram. Upon initial intubation, we'll typically be at 8 milliliters per kilogram and try to decrease the tidal volume in order to get to 6. And so typically, like I mentioned earlier, we have that P-plat, which is our plateau pressure, and we want that to be less than 30 centimeters. If the P-plat pressure is high, you can go down on the tidal volume by 1 milliliter per kilogram. Now, our oxygen goal is both a measurement by our ABG and the pulse ox. So we want to be a PaO2 of around 55 to 80, and we want the oxygen saturation between 88 to 95%. Now, if you draw an ABG and you see that the pH is less than 7.3, you can think about increasing the respiratory rate, and you typically want to do this up to a max of 35. Now, there have been many studies that have shown permissive hypercapnia has been shown to improve outcomes in patients with ARDS. So if you start approaching a respiratory rate close to 30, I would involve your senior or attending before continuing to make increases to your respiratory rate. Now, while you can use FiO2 and PEEP to manipulate oxygen support, another thing you can do is to prone a patient. So when a patient is lying on his or her belly, the VQ match is actually improved. So you're perfusing highly ventilated areas. You can consider proning in patients that have a PF ratio less than 150 and have an FiO2 greater than 60%. You can do proning with or without paralytics. This is often attending dependent. Now, typically we'll have patients on a 10 to 2 schedule. Sometimes we'll do a 16 and 2 schedule. But this is when you have a patient on their belly for 10 hours. You'll flip them. You'll keep them on their back for 2 hours supine, and then you'll flip them on their belly again. And so we will typically do this with Q2 head turns. Now, typically, when someone is prone, nursing will typically ask you if you can put a CORTRAC order in. And so what CORTRAC is it's a weighted feeding tube that its destination is post-pyloric. And the rationale for that is with proning and moving around, you don't want to have an NG tube or an OG tube slip from the stomach up into the esophagus or get retracted. So post-pyloric adds an additional obstruction from slippage. And just as an FYI, while most or any nurse can put in an OG or an NG tube, there are only a few nurses that are qualified to do a CORTRAC placement. And whenever you have a patient prone, Typically, they need one-to-one nurse attention. Now, you can consider stop proning if you draw an ABG and your PF ratio is greater than 150. And you typically draw this ABG when your PEEP is at around 10 and your FiO2 is around 60%. Now, when patients are doing well on the ventilator and you're starting to think about removing the support, you'll have to do something called a spontaneous breathing trial, an SBT. So what this happens is, as it sounds, is you allow the patient to spontaneously breathe with minimal support. And so typically what you're doing is you're going to still provide oxygen and pressure support, but you're going to provide it the CPAP machine. So you're going to have a CPAP pressure around 5, and you'll be giving extra oxygen support with an FiO2 of around 50 or less. So you typically will do this when your FiO2 requirements are around 50 or less, and your PEEP requirements are 7.5 or less. Your minute ventilation should be less than 12 liters per minute, and this is essentially trying to rule out acute distress or the possibility of fatigue. And you have to be off of pressure support. Now, the exact requirements to do SBTs vary between attendings, and sometimes we like to do SBTs without the hope of extubation, but instead as an exercise to hopefully build back some of the breathing mechanics. SBTs fail for several reasons. I'm just listing a few here. So the RSBI is the Rapid Shallow Breathing Index, and this is essentially just the respiratory rate divided by the tidal volume. So if you have a respiratory rate of 20 and your tidal volume is 500, your RSBI would be 40, and so that would be great. But if you were taking really rapid, shallow breaths, say your respiratory rate was 30 and you were only taking 200 cc's per breath, your RSBI would be 150, and so that wouldn't be sustainable. So if you're over 105, it has a really good predictive value of failing extubations. Now, other fails would include excessive secretions, hypoxia, anxiety, or the underlying cause worsening. Now, when these requirements are met, we typically try to do SBTs daily, and we typically do SBTs in the morning. The main rationale for that is if a patient is extubated and they don't do well, you want to have a lot of personnel and a lot of physicians nearby in order to proceed with reintubation. When we have people on the ventilator, we have to have sedation. And so I'm just listing a few of the sedatives that we use, and I'll talk about each of their pros and cons. So probably the most used medication that we use is propofol. The main rationale for that is it's quick on, quick off. It has great sedative effects. Some of the adverse effects are increased triglycerides. Propofol is a very lipophilic agent, and so it has a lot of lipids when you actually infuse. Now, it has adverse effects of also decreasing your blood pressure, also decreasing your heart rate, but we mostly think of blood pressure. Now, it is very high volume. So if someone is requiring fairly high dose of propofol, say 60 or 70, that'll actually lead to about a liter of intake. And so this is something you definitely have to watch in heart failure. Now, propofol also has the adverse, unpredictable respiratory depression compared to some of the other agents, but still, it's one of the safer drugs. Now, Precedex is a really good medication, and so the pro for it is it's okay with non-ventilator patients. It has less effect on blood pressure. It still does have some blood pressure effects, but not quite significant as propofol. Now, the main adverse effect for Precedex is its heart rate depression. So when you're deciding between propofol and Precedex, you typically want to look at blood pressure and heart rate. More importantly, the blood pressure. So if a patient is already on pressors and they're needing intubation, I would think first about doing Precedex. If you do propofol, just remain cognizant that you're probably going to have to go up on pressor support. Now, another medication that's not quite as used, but is still a really good medication is ketamine. It has the pro effect of maintaining a MAP and a patient's respiratory drive compared to propofol. And its adverse effects, however, delirium and agitation. And now, fentanyl is another sedative we use. It's never used alone for initial sedation, and it's used as an adjunct, so in addition to one of the three above. Now, the pro for it is there's no dose adjustment in liver or kidney failure. The adverse effects of fentanyl are that it decreases your heart rate and decreases your blood pressure to lesser degrees than propofol and Precedex, but still needing to be addressed. And it decreases your GI motility. And a last effect is it tends to accumulate with prolonged use. So if you have an elderly patient on the ventilator for 2 weeks and they finally get extubated and you're starting to wean from fentanyl, it's not going to be the quick on, quick off that we typically think of fentanyl because it's been on a drip for so long. Now, another thing that we think about are paralytics, and I addressed this a little bit with proning, but I want to talk a little bit more about it. So, we consider paralytics when we need to think about controlling breathing mechanics. If you have a patient that is going to be proned and you don't want them to be moving around for their safety and also to control breathing, you can think about using Nimbex. And so we usually think about this for proning. You can use it when you're not proning, and that's typically when you stop proning and you continue Nimbex for about another day. Now, when you do paralytics, you have to have adequate sedation. So you don't want to have someone awake in the mind but not being able to move their body. That's torture. And so typically you will always use propofol in addition to fentanyl, maybe Precedex on board as well. And I've seen people on propofol, Precedex, ketamine, and fentanyl. Now, one thing I want to mention is that when you have someone on Nimbex, they're receiving a few liters a day of fluid. And so this is something you definitely need to be cognizant in people who have heart failure or kidney failure. Now, I'm going to talk just briefly about COVID management because by the time you're listening to this, this is probably all inaccurate. So for dexamethasone, typically in the ICU, we will do 20 milligrams to start. And the amount of days that you do it for is very attending dependent, but I've seen this protocol by several different people. And so it's 20 milligrams for 5 days. You do 10 milligrams for 5 days after that. And sometimes you'll stop there. Sometimes you'll continue to taper to 6 milligrams. You can continue for a few days. Now, I've also seen 20 milligrams continued for up to 2 weeks, and I think a lot of it depends on the clinical trajectory of that patient. In patients who are intubated or have had some sort of non-invasive ventilation, we want to think about baricitinib. And so this is typically within 24 hours of escalation to higher oxygen support, and so you will either do baricitinib or tocilizumab. The main indication for doing tocilizumab would be if you had kidney failure with a GFR less than 15. Otherwise, you would do baricitinib. And so for baricitinib, it's renally dosed. And so if you have normal kidney function, you would be at 4 milligrams a day. However, if you have a GFR between 30 and 60, you would be 2 milligrams a day. And if you have a GFR between 15 and 30, you would have 1 milligram a day. And if you're less than 15, you don't use baricitinib. Now, tocilizumab, while it is a one-time dose, it remains in your system for approximately 10 to 14 days. So if someone's kidney function improves and they've already received a tocilizumab dose, you wouldn't want to then do baricitinib. Now, in addition to some of the medications we've talked about, Lovenox, typically the dose is increased for COVID. Some people will do therapeutic Lovenox. Some people will do a hybrid where it's just double the normal dose, but not quite therapeutic. And then we don't do remdesivir as much in the ICU because those are typically for hospitalized people that aren't as severe. Now, if someone was started on remdesivir and they are transferred to the ICU, I've seen it both ways where remdesivir is continued, but I would say typically it's discontinued at that time. And I haven't seen the monoclonal antibody used in the ICU. Those are for people who have minor symptoms, and the main rationale is to not take a hospital bed and to instead prevent hospitalization. Now, I just want to mention one thing for baricitinib and tocilizumab is you will need to stop both of those if you have a suspected bacterial or fungal infection. Now, I'm going to start talking about some topics that are not oxygen support. Yes, we see non-COVID or non-ventilated patients in the ICU, and talk about some of the other indications for admissions to the ICU. So one would be pressure support. So typically, once someone is on a pressor, they will have to be considered for ICU management. And so the pressors that we use are typically one of these four. So the first and definitely the blood pressure support med that you should think of is Levophed. And so Levophed is a beta and alpha agonist, and so it increases cardiac output and increases your systemic vascular resistance. It leads to better blood pressure support. The downside is you have to be very careful in arrhythmias. So another medication you could use is Neo, and so this is just phenylephrine. This is a pure alpha-1 agonist. So the downside to this is it doesn't have the beta effects. So it does not increase cardiac output. It essentially just clamps down your arterioles, and so it might not actually lead to increased perfusion. It leads to better blood pressure support, that's for sure, but maybe not better end organ perfusion. The main indication is for neurogenic shock, but I have seen it in many other indications. So one caveat is you consider starting Neo if a patient has an increased heart rate or arrhythmia at baseline. Now, in a lot of these people, they're going to be hypotensive, so they're going to have respiratory tachycardia. And now if they're at a heart rate of 100, 110, I still think it's totally fine to start Levophed. But if they're tacking away at 150, 140, I would consider starting Neo. And this is definitely a conversation that you can have with your senior or attending. We will oftentimes use more than just Levophed. So if we do Levophed and still not working, then we can jump to Neo. And a typical Levo starting dose is 5 mics per minute and titration by 5 up to 50 as a max. So it's 5, 5, 50. Now Neo is typically you start at 20, you can go up to 200, and you titrate by 20. So it's all the 20s and 200s and Levopheds, the 5 and 50s. So that's just an easy way to remember it. Now, vasopressin is just ADH, and it has a completely different way of working. It increases your preload, increases your intravascular volume due to the ADH effects, but it also slightly increases your SVR. And the main indication for vasopressin is in septic shock. In contrast to Levophed and Neo, it's a fixed rate. It's at like 0.3 mics per minute. And then the fourth thing, it's a last-ditch effort, stress dose steroids. So you're trying to think, well, if it's not a cardiac output issue, if it's not an SVR issue, it's not an intravascular volume issue, maybe it's some sort of cortisol insufficiency. And so we're going to try the stress dose steroids. And so there are two main different dosing regimens. There's 200 milligram and a 300 milligram. So for the 200 milligram, it would be 50 milligrams Q6. Or it'd be, for the 300, it would be 100 milligrams Q8. I've seen the 50 milligram one used more commonly, but at this point, either of them would work. Now, a common page you'll often get for Levophed is, can I titrate by 1 mic per minute? And typically, you're going to get that page when a patient's on Levophed, they're at a very low dose of Levophed at 5, but when they turn it off to 0, the patient's blood pressure declines. So they need some sort of requirement between 0 and 5, so titrating by 1 is a good way of getting at that. Now, another indication for the ICU is kidney failure and needing some renal support. So there are two main classes of renal replacement therapy. There's hemodialysis, HD, and hemofiltration, H. And so hemodialysis, as we're most familiar with in the chronic CKD patient, removes small molecules. So it removes your BUN, it removes your potassium, and it's usually intermittent. And typically you'll use an AV fistula or a hemodialysis catheter. Now, hemofiltration is a little different. It removes small and large molecules. The helpful part of it, or the major difference, is that it can remove cytokines. So in patients that have ARDS or some sort of sepsis picture that are having ATN, kidney issues, this can be very helpful. You can remove the underlying cytokines that are leading to ATN. Now, the hemofiltration can be intermittent or continuous. Typically, it's continuous, and this will require an HD catheter. You can't use it through an AV fistula. And so when you're reading nephrology notes and you're seeing all the different abbreviations they use, it's best just to break it down by letter. So the C is continuous, I is intermittent. Continuous has to be done at the bedside. So that would be an indication for someone having to go to the ICU. Is you don't take someone to continuous renal replacement therapy, you take them to the ICU and renal replacement therapy comes to them. VV is venous venous. HD would be the hemodialysis, and H would be the hemofiltration. So you can create the acronym CVVH, which is continuous veno-veno hemofiltration. Now, one additional component is if you have a patient who is on hemofiltration, they're on continuous hemofiltration, so they're on CVVH, and they are starting to step down from the ICU, you're thinking about doing intermittent hemodialysis, just know that intermittent hemodialysis has a larger hypotensive risk than CRRT. Now, cardiac arrest is another indication for the ICU, and these people will be in cardiogenic shock oftentimes. And so this is a case where you can consider dobutamine. Just remember, dobutamine, while it favors beta 1, it has substantial beta 2 effects, so it can actually worsen hypotension while increasing cardiac output. The use of targeted temperature management has had its ups and downs. And so initially it was in favor, it dropped out of favor, now it's kind of coming back and possibly now dropping out. But there are two main different temperatures. There's the 33 degrees Celsius or the 36 degrees Celsius. And like I mentioned, the benefits are debated. So this is definitely a decision to talk about with your attending. But the indications of using TTM currently are if there's no purposeful movements. So if you're seeing myoclonic tics or myoclonic movements, that's not purposeful, so that wouldn't count. If you do TTM, those are typically the two temperatures that you'll do. Now, while you might not do TTM, you will still want to prevent fevers, and that might be the new school of thought coming out, that cooling isn't as helpful, and rather it's preventing fevers. Now, whenever someone comes into cardiac arrest, the Indiana Donor Network, the IDN, will be notified and they will be in contact with nursing. And if the IDN wishes to proceed with organ donation, they will require a brain death declaration. And so brain death is something that you will see in the ICU. So when we think about brain death, it's good to take it a step at a time. So first, we want to make sure they're normothermic, they're normotensive. We're correcting potential underlying causes such as stroke, such as electrolyte imbalances. And so we want to have a very comprehensive workup before we move to step 2. So step 2 is checking for absent cortical brainstem function. So this is withdrawing to pain, doing a lot of your neuro exam, doing your brainstem reflex exam. And now if both of those are negative for function, then that person is brain dead and you can proceed to step 3, which is an apnea test. However, if a patient doesn't have cortical function but maybe has a reflex, a brainstem reflex, then you can proceed to additional workup such as an EEG or nuclear medicine perfusion scan. And now if you make it to step 3 and they don't pass the apnea test, they are brain dead. It can be sometimes a helpful or a hard conversation to have with family that they're technically dead and you do not need to talk about comfort care conversations any longer. When someone is admitted for sepsis, they're very volume depleted, so you want to have a large volume repletion of crystalloids within the first few hours. So this is typically 30 milliliters per kilogram within the first few hours, with the max usually around 3 liters. You want to have them on broad spectrum antibiotics, and that's typically vancomycin. There's been some literature that vancomycin lead to increased renal injuries, so you can think about vancomycin. And you can consider meropenem if there's concern for ESBL. And so if someone has a prior ESBL culture or if they've been frequently hospitalized. Now, interestingly, it's been discovered that the lactate trend is more important than the absolute number. So while it's helpful to have a lactate, it's really the subsequent lactates that are very helpful. And so if you start to downtrend, but you're still elevated, that's usually fine to stop. And then pressors are used to maintain a MAP. And typically, like I mentioned, you can think about Levophed right away. And while you want to have central access for long-term pressor support, it's okay to start pressors peripherally. Okay, and so next we have COPD exacerbation. And so this is just going to be the hot hitters. So you're going to want some Duonebs. You're going to want to do a steroid burst on them, typically for 5 days. You can do prednisone or methylprednisolone, typically the 40 milligrams. For antibiotics, if it's someone that comes in without high risk for Pseudomonas, such as a prior Pseudomonas infection coming from an extended care facility, you can usually get away with ceftriaxone and azithromycin for a 5 to 7 day course. And if they are higher risk, you'll have to do levo, zosyn, or cefepime. And then you'll typically want to put them on non-invasive ventilation. For GI bleeding, acute management is all about volume repletion. So right away, you're going to want to do packed red blood cells over IV fluids because IV fluids will dilute clotting factors and platelets. Once stable, you can do IV fluids. Now, if you're going to do IV fluids, you're going to want to do normal saline over LR. The main reasoning is the citrate from LR will bind to packed red blood cells and form clots. Now, if a patient is unstable, you're going to want to do IV pantoprazole 80 milligrams and then do an 8 milligram per hour drip, and then make sure to call GI. If you're suspecting variceal bleeding, you will add octreotide and then ceftriaxone for SBP prophylaxis. Now, just as a note, hemoglobin, as you probably know, takes hours to reflect blood loss, but still, that's something that we're still going to want to check because a lot of people, particularly ICU patients, will bleed unobserved. And then always remember to stop heparin drips and stop enoxaparin if you're suspecting GI bleeding. And now, rule of thumb for repletion, particularly those who need large transfusions, is a 3-1-1 of 3 units of packed red blood cells, 1 unit of platelets, and 1 unit of FFP. And since we're talking about blood products, we can briefly go over with a 10,000 foot view. So I'm sure a lot of y'all know about the transfusion for packed red blood cells if your hemoglobin's less than 7 or less than 8 if it's a cardiac patient. For platelets, we typically think of less than 10,000 for most people, less than 25,000 for minor procedures such as central lines, and less than 50,000 for active bleeding or major surgeries. And every platelet unit that you give increases the platelet count of around 25,000. Now, you can give FFP if you're requiring a rapid repletion of all coag factors, such as those in DIC or TTP. And if you're really concerned about warfarin reversal, instead you can do PCC, which is just the rapid repletion of vitamin K coag factors. Now, we'll do a quick talk on IV fluids. So the main two crystalloids you're going to do are normal saline and LR. Normal saline has a pH of around 5.5, so caution in severe acidosis. Normal saline osmolality is about 286, and that's exactly what normal blood osmolality is as well. And some adverse effects is you're going to have a non-GAP metabolic acidosis anytime you give normal saline, and there's going to be associated hyperkalemia secondary to that acidosis with the pH of 5.5. Now for LR, the pH is more basic, still acidotic at 6.5. However, it's a little bit more helpful in sepsis-like pictures. LR is hypotonic, so you're not going to want to use this for increased ICP, just as well as you're not going to use half normal saline and anytime you have concern for ICP pressure elevation. In addition, while LR is used in acidosis, that has an additional benefit, and some of the lactate is converted to bicarb, which is favorable in acidosis. And of note, lactate will not be elevated with the use of LR. So now we want to talk about seizures. So if you are called to the bedside because someone is actively seizing, you're going to want to treat it as a true seizure and not try to decipher whether it's a pseudo seizure to start. So you're going to put the patient in a left lateral decubitus position. You're going to suction to bedside. You're going to want to prevent aspiration. For initial management, you can start with some Ativan, then you can throw 1 amp of D50 in case the patient's hypoglycemic. Now, if the patient, despite these measures, are not treated, you can be concerned about status epilepticus, and then you can start an Ativan drip at 2 milligrams per minute and consider a phenytoin drip. Now, once you fix the patient, you're going to want to really figure out why this happened. So do your laboratory workup, and if you're wanting to confirm that this was a seizure and not a pseudo seizure, you can check prolactin. Now, if a patient is a repeated offender of all these seizures and there is concern for pseudo seizures, you don't have to do the initial management of D50 and Ativan. You can trust your physical exam and try to do maneuvers that can delineate pseudo seizure from seizure. But this workup's pretty helpful if this is a new seizure. In patients that are hypertensive, you're going to want to decrease the MAP to about 25% within the first hour. You're going to want to decrease the blood pressure subsequently after that to around 160 systolic and 100 diastolic within the next 2 to 6 hours. Now, we typically will do that with labetalol PRNs, esmolol drips, or nicardipine drips. You will routinely get pages about patients have altered mental status or concern for encephalopathy, and you should always consider hepatic encephalopathy, particularly in cirrhotics. And so, of note, routine monitoring of serum ammonia is not recommended. It's still routinely done in the ICU, and it's more helpful as a rule out. So if a patient's altered and they have a normal ammonia, it has a pretty good negative predictive value for hepatic encephalopathy. But if a patient has known reasons for hepatic encephalopathy, and this is typically how they behave, it's not necessary to measure. Now, in patients who have hepatic encephalopathy, typically you want to do lactulose and rifaximin. Some patients will just have one of them. Lactulose is titrated at 2 to 3 bowel movements a day, and you can perform lactulose enemas for those who are NPO. Rifaximin is a fixed dose, 400 milligrams PO Q8. Most patients with acute pancreatitis are managed in the wards and don't require ICU level of care. However, some severe cases are seen in the ICU, and management is pretty similar between the two different units. So you're going to want IV fluid repletion. This is typically 3 to 4 liters in the first 24 hours. And importantly, you're going to want to avoid prophylactic antibiotics and start early oral feedings, typically low fat, because you don't want to have to stimulate the pancreas to create lipase. Enteral feedings are only used in severe cases, and when you do this, you typically will do an NG or NJ, so not distal to the pancreas. Similar to pancreatitis, DKA and HHS can be managed in the wards and not in the ICU, but we'll quickly go over it. So IV fluids, you're going to want to do volume resuscitation with normal saline or LR, keeping in mind normal saline is more acidotic. And in patients who do have DKA, I would more jump to LR. HHS, they're less acidotic, and you can probably get away with normal saline. You can switch to half normal saline once the patient's fully resuscitated, and then you're going to want to add some dextrose once the blood sugars are less than 200. You're going to be checking the potassium Q4 with BMPs, and you're going to want to replete the potassium if needed, and you're going to add potassium in the maintenance fluids if between 3.3 and 5. So your target blood sugar decline is about 70 to 100 per hour, and you will stop the insulin drip if your potassium is less than 3.3. So hopefully with repleting at the Q4 BMPs and having potassium in your maintenance fluids, you don't get under 3.3, but remember insulin will drive potassium into the cell. So you will eventually do long-acting insulin, and this is either NPH or Lantus, and you're going to want to make sure you overlap with the drip for 2 hours once the gap is closed. Now, the use of bicarb is very controversial. It hasn't been shown to have any benefit and might be detrimental if the pH isn't significantly acidotic, but its use is seen if the pH is less than 6.9. One conversation that you're going to have in the ICU more than any other setting is code status. Do not resuscitate comprehensive care, as we will do absolutely everything except CPR. So that means we'll give pressors, we'll allow mechanical ventilation, we'll still give all medications that are potentially life-saving. And then comfort care is the opposite of that. So we're going to remove all potential life-prolonging measures. And so this will require extubation. This will allow for medications that help with pain and anxiety, but otherwise will discontinue those that do not. And it is an order set, which is called end-of-life/terminal wean. Now, comfort care is symptomatic treatment only, like I mentioned with the pain medications, oral secretions, and a lot of these things will be in that order set. Now, if a patient remains in the ICU for greater than 6 hours, consider transfer to hospice. Now, I have seen some scenarios where families want to proceed with a sort of a hybrid between comfort care and comprehensive care, where they want to stop blood pressure support, they don't want any more pressors, they don't want any other medications, but they want the patient to still remain on the ventilator with minimal oxygen support, continuing some of the sedatives. Typically, once patients get to the point of doing comfort care, they're usually okay with all the measures of comfort care, including extubation. And when you do this, if a patient does have baseline oxygen needs, usually we try to extubate them to those oxygen needs. Now, high residuals is something that you'll get paged about a whole bunch. Essentially what it is, it's nursing protocol. Every so many hours, they'll see how much residual is left in the stomach. And so it's the number of milliliters suctioned via an enteric tube. And there's a nursing protocol If they reach a certain amount, they'll hold tube feeds, they'll give it back, and this and that. You won't get paged for those scenarios. You'll get paged after nursing has already tried their troubleshoots. It hasn't worked, and so they're reaching out to you. So there's a few things you're going to have to answer. Are you going to continue or stop the tube feeds? I would always err on the side of caution and stop tube feeds when in doubt. And then the next is, do you give back the residuals or do you discard it? And so there's a few factors. I think the proximity to medications given enterically is important. I don't want to withhold medications that are probably in the residual. So if we're close to having medications given, I'd be more likely to give it back. The color, so if it's more tube feed, I'd be more likely to discard. If it's more bilious, I'd be more likely to discard. If it's more, looks like saline, looks like more meds, I think that would be okay to give back. And the amount, so if it's greater than 300, just consider discarding at baseline. And if it's more than 500 cc's, you can consider advancing post-pyloric. Now, if this is an issue over the course of a few days, you can consider Reglan metoclopramide to increase GI motility, but beware of the EPS, extrapyramidal symptoms in long-term use. Now, most of our patients in the ICU are going to have some sort of long-term access via a central line or a PIC. PICs are great for long-term infusions, particularly patients that will have to go to LTACs on antibiotics. And so our PIC is actually done by a nursing team. Some of the contraindications to having a PIC are bacteremia, because the assumption is you will seed the catheter, AKI or ESRD. The main reason is you want to preserve veins for HD catheter use or AV fistula use, and a history of trauma or radiation surgery to that arm. Like I mentioned, it's placed by the PIC RN, so it's not available 24/7. They are 7 days a week, but not at night. So if high priority, either do the central line yourself or call the PIC team and really advocate for your patient. Now, when you place a PIC, you don't always have to get a chest x-ray afterwards like you do with central lines. The PIC team actually has a way of sensing the location of the catheter tip using the cardiac electrical activity. Bowel movements in the ICU or something you're going to definitely be concerned about. Many of our patients haven't had bowel movements for many days despite some scheduled Miralax or Docusate. And a lot of the issues are due to fentanyl drips. A lot of these times we'll have patients on 150 mics of fentanyl an hour, and they have that for days and days. And like I mentioned earlier, fentanyl really builds up. And we're going to be having high residuals oftentimes, so tube feedings will be held, and so bowel movement is less likely to happen from that. And a lot of our patients are on pressors, and they're going to have hypotensive episodes where there is gut malperfusion. If despite the scheduled medications such as Miralax, Docusate, you're still not able to promote a bowel movement, mag citrate will work, and that's usually a last resort. And if patients really are having a lot of bowel movements and it's very difficult for nursing, oftentimes nurses will reach out to you about placing a rectal tube. The caveat is they will need to stool before placing the rectal tube. Most, if not all, of our patients are on heparin products, and so there's often concern for HIT when platelets drop. And so just as a reminder, HIT typically happens 5 to 7 days after starting heparin. Now, while HIT usually happens with heparin, it can also happen with Lovenox. And then also as a reminder, thrombosis is common in HIT and actually precedes thrombocytopenia in about a quarter of cases. So when you suspect HIT, you're going to want to do three main things. You're going to want to stop the underlying cause or potential underlying cause. So stop the heparin, stop the Lovenox. You're going to want to have them on therapeutic anticoagulation, so argatroban or fondarapinib. And then you're going to want to diagnose it. And so you're typically going to send both of these as well as a CBC to confirm a 50% platelet drop in the last few days. So you're going to want to send HIT antibodies, which are very sensitive, and a serotonin release assay, which is very specific. Enteral nutrition is best, but TPN can be indicated if you have a non-functional GI tract, such as a patient obstructed, has gut ischemia, or in patients who are unable to obtain enteral access, and you must have central venous access. Now, one of the more common pages you'll get is about a patient with a fever, and you should ask yourself, were there recent blood and respiratory cultures? If not, redraw them. Always err on the side of caution of redrawing cultures. Are they on antibiotics? If so, are they broad? If they're not fully broad, broaden them. If you were triggered to redraw cultures, your suspicion was high enough, your suspicion should also be high enough to put them on antibiotics. And you'll always get the question of whether or not you should treat the temp. I would say most attendings probably treat if over 102 degrees, and it's usually okay to give Tylenol, but if a patient has had some Tylenol and they're not responding well, consider physical measures such as a cooling blanket or ice packs around their axillas and maybe a fan. Another common page is, am I able to use the OG or NG tube? And this is nursing protocol that whenever they place some sort of enteric access and we get a chest x-ray after, we have to have physician approval. And so an easy thing you can do is open up the radiology report and see where the radiologist said the enteric tube ended. Another thing you can do is open up the radiograph yourself and confirm the suction hole. The opening of the radiopaque line is below the GE junction. And so essentially what that line is telling you is that's the most proximal part of where you're going to suction, and you don't want to suction the esophagus due to risk for ulcers. And now just a few ICU hot hitters. So the MRSA PCR is only for respiratory infections. So if you have a patient status post-surgery and their MRSA PCR comes back negative, you might get a page from pharmacy asking you to withdraw Vanc, but for those patients, you should still have them on Vanc. You're going to want to caution using Lovenox in renal failure because it's renally excreted. If you're going to place any antibiotic regimens, you can always do the order consult pharmacy for blank dosing. That could be Vanc, Zosyn, Cefepime, Meropenem. That's just a great resource for you, especially for patients who have renal issues. Another use of pharmacy is to consult them to transition medications from oral to by tube feeding or vice versa. If an NG or OG tube is post-pyloric, aspirin must be rectal because aspirin is gastrally absorbed and there's also some rectal absorption. And consider a trach and peg if a patient is intubated and approaching 14 days. Around the 14-day mark, the risk for vocal cord edema, stricture, ulceration increases, and typically when we're considering trach, we're also considering peg. I know this was just an introduction to many of the different topics that you're going to see in the ICU, but I really, really hope it was helpful. I hope you feel more prepared to take advantage of the wonderful learning environment in the ICU, and I thank you for listening.